Bismillahirrahmanirrahim. Alhamdulillah wassalatu wassalamu ala rasulillah wa ala alihi wa sahbihi ajma'in. Allahumma anfa'ni bima 'allamtani wa 'allimni bima yanfa'uni wa zidni 'ilman innaka al-'alimul hakim. اللهم أخرجنا من ظلمات الوهم وأكرمنا بنور الفهم وافتح علينا بمعرفة العلم وسهل أخلاقنا بالحلم. اللهم ارزقني نعمة الإخلاص لوجهك الكريم بكل ما أقول وبكل ما أفعل. آمين يا رب العالمين. My topic today is about the normal variant of brain ventricles or ventricles normal variants. The essential diagnosis of this topic, it is normal variant of the ventricles of the brain are asymptomatic and are varies from with side. Lateral ventricles are common, fourth ventricles are less common, third ventricle variant such as thick floor, uncommon and rare at imaging but important for endoscopic operation. Clinically, the patient may come for headache, bubble edema, and history prior to trauma or infection. The differential diagnosis, the common causes, asymmetric of the lateral ventricle, intraventricular pulsation artifact, flow-related artifact, Cavum septum pellucidum and Vergae, coarctation of the anterior horn. The asymmetric of the lateral ventricles, it is leaflet of the septum pellucidum and pushed to a smaller ventricular side. Asymmetric of the lateral ventricle, last normal hemisphere, usually normal variant, exclude obstruction at the foramen minor, cyst or web, or a tumor can cause asymmetry of the lateral ventricle or sometimes mass effect. Asymmetric of lateral ventricle with abnormal hemisphere, large hemisphere, we have megaencephaly, lateral ventricle large and often deformed, smaller hemisphere, unilateral atrophy or borencephaly. Asymmetric lateral ventricle sign of functioning shunt if shunt is in smaller ventricle. Helpful technique in evaluating ventricles for possible obstruction: sagittal coronal thin section T2 weighted image, high resolution visita, CSF flow study, intraventricular contrast, outline obstruction, intravenous contrast helpful in detecting a small lesion. Here we see CT scan of the patient. We have asymmetric of the lateral ventricles, and we see the left side is smaller than the right side, and here in another patient the right side is smaller than the left side. Here is another patient with asymmetric of the lateral ventricles. The left lateral ventricles, anterior horn and the body are smaller than the right one. And this is a flare and this is T2 weighted image. Intraventricular CSF pulsation artifact, it is most common in high field MRI. Flare sequence are the most common affected, and we should look for another sequence or another plane if the artifact are disappear or not. Typically occur in phase encoding axis. Look for phase artifact propagating across image. When in doubt, change the phase encoding direction and repeat the sequence. Here, this is a patient with a FLAIR image, and we see left intraventricular high signal corresponding to pulsation artifact. Here, in another patient, there is pulsation artifact in the fourth ventricle, and we see also this 3D flare, cube flare, there is the artifact is removed, and this is a good example for the removing the artifact from 2D flare to 3D flare. Here another patient with pulsation artifact in the lateral ventricle, and also see the artifact in the fourth ventricle and the third ventricle, and in 3D flare images the artifact is not seen. Cavum septum pellucidum and Vergae, it is a developing ventricle closes from posterior to anterior. Therefore, Cavum Vergae does not occur in isolation. Cavum septum pellucidum can exist plus with minus Cavum Vergae, but not the reverse. Cavum septum pellucidum lacks ependymal lining. Term fifth ventricle is inaccurate. Cavum septum pellucidum leaves should parallel. If the septal leaves are not parallel, considered encysted cavum. Look for signs of obstructive hydrocephalus and look for evidence prior to trauma with EBI gradient sequence or susceptibility weighted image to detect hemorrhagic residua. Here, this is a normal patient, and here this is the cavum septum pellucidum between the frontal horns. Here another patient, cavum septum pellucidum between the frontal horns of CSF density, intensity in this T2 weighted image. Here another patient, we have the CT scan, small CSF density between the frontal horns and the coronal MRI. It is a cavum septum pellucidum, and the cavum septum pellucidum, it is seen in 85% of term infants and in about 1 to 15% in adults. Here another patient, we have cavum septum pellucidum between the frontal horns. Another patient with cavum septum pellucidum, as we see a drop-shaped thickening of the posterior aspect of the fornices here, and this is parallel to the frontal horns. Here, this is a patient, the same patient previously with cavum Vergae. It is parallel and bored to the lateral ventricles. Another patient with cavum Vergae, pellucidum and Vergae in this patient. Here, this sagittal view with patient with upward bowing of the fornix due to and also the internal cerebral vein, it is downward displacement due to cavum septum pellucidum and Vergae. Here, another patient with cavum septum pellucidum and Vergae. Coarctation of the anterior horn, it is a normal variant. We should exclude subependymal pseudocysts seen with inborn error metabolism, torch, ischemia, and finding helpful in distinguishing coarctation of the anterior horn from the pathologic subependymal pseudocyst, perioxomal, peroxisomal biogenesis disorder, Zildjian disease, cortical dysplasia, hypomyelination, and stable epiphysis hypotonia, mitochondrial disorder, MR spectroscope black tate doublet, torch cytomegalovirus, look for macrocephaly and calcification in the periventricular region, hypoxic ischemic insult history of perinatal distress. Here we see neonatal patient with ultrasound, and we see echoic line and the frontal horns representing the coarctation, and we should not to be mistaken by periventricular cyst. Here another patient with coarctation, and we see the line, and here this is the sagittal cut. Another patient with coarctation, as we see here in this T1 weighted images, and this is T2 weighted images of the same patient. Less common causes, we have Connatal cyst and Germinolytic cyst. Connatal cyst, considered a normal variant, may be anterior choroid plexus cyst. It is controversial entity, transient finding, present at birth, spherical form, can be multiple, lined by epithelium, partial double wall, no homocysteine, no septation. As we see here, this is the flare images, and this is the T2, and we see bilateral connatal cyst in this patient, and another patient with connatal cyst here, and T2 and the flare images. Germinolytic cyst, it is juxtaventricular subependymal pseudocyst, a result from germinolysis, lined by germinal/glial cell, not ependymal cell, may have hemosiderin, may have septation, probably not a normal variant, and rarely isolated. Look for other signs of CNS pathology distinguished from connatal cyst. Here, this patient with a newborn, flare images with seizures, and we have cyst with fluid level in the caudothalamic groove. Rare causes, it is open inferior for ventricle, a black pouch remnant, and it is presence of complete vermis, fastigia versus differentiated black pouch remnant from Dandy-Walker cyst, usually non-obstructive, visitor and CSF flow sequence may be helpful. Thank you for listening and hoping to see you soon in another talk. سبحانك اللهم وبحمدك أشهد أن لا إله إلا أنت أستغفرك وأتوب إليك.